so they are activated after exposing to the antigens. Then we have the paracortical or paracortex. After that, we have the medulla. This is the normal structure of the lymph node. طيب بالهistology, normal histology of the lymph node under the microscope, primary follicles حكينا بتكون concentric, naive, inactive lymphocytes, aggregates of lymphocytes, look like what the primary follicles, dark blue follicles. While the active or reactive follicles, secondary follicles, contain germinal centers in the center with reactive lymphocytes surrounded by mantle zone, and the outer layer is the marginal zone. ليش بنحكي عنهم؟ لأنه رح نحكي عن lymphomas composed of cells resembling cells in the mantle zone, the marginal zone, and cells resembling germinal center zone cells. So, we will start with the chronic lymphocytic leukemia or small lymphocytic lymphoma. They are identical entities, both of them, CLL, SLL. The difference was involvement of the blood with malignant lymphocytes. If the blood shows lymphocyte count more than 5,000 per microliter, then we have CLL, chronic lymphocytic leukemia. It's the most leukemia of adults in the Western world. The small lymphocytic lymphoma in the lymph node, is a low-grade lymphoma, only account 4% of non-Hodgkin lymphomas. So it is not common in lymphoma, in SLL. CLL, اللي هي leukemia, اللي هي most common leukemia in adults in the Western world. The course of the CLL, SLL is indolent, slowly growing tumor, characterized by immune dysregulation with accumulating cells suppressing the normal cell function. So we have hypogammaglobulinemia with increased risk of infection. About 15% of patients of CLL develop autoantibodies against their own RBCs. If we have autoantibodies against the RBCs, then the patient will present with what? With anemia, اللي هي hemolytic autoimmune, or autoantibodies against the platelets as well, while the patient present with thrombocytopenia. These autoantibodies are made by non-malignant B cells, normal B cells. They found that they are secreted by the bystander B cells, اللي هم non-malignant, indicating the impaired immune tolerance in patients with chronic lymphocytic leukemia. Morphology, if we take a lymph node from a patient with SLL, we will see effacement of the architecture. We will not see lymphoid follicles, like normal lymph node. Effacement by sheets of small lymphocytes and scattered foci of larger cells, active cells called what? Pro-lymphocytes. Tamam? These foci of active pro-lymphocytes through the lymph node called proliferation center. Proliferation centers is pathognomonic of SLL, small lymphocytic lymphoma. The presence of these proliferation centers بتكون عبارة عن collection of pro-lymphocytes. In this picture, on the top, you can see effacement of the normal histology of the lymph node with scattered pale foci. يعني pale foci focus بيكون موجود throughout the lymph node. لما ننزل عليهم these foci containing what? Collection of pro-lymphocytes. lymphocytes اللي هم بيكونوا active with open chromatin, prominent nucleoli. These are the proliferation center حكينا pathognomonic of SLL. Peripheral blood لما يكون في عندنا CLL اللي هو chronic lymphocytic leukemia, we have absolute lymphocytosis, lymphocytes more than 5,000 per microliter. Blood film will show smudged cells. Smudged cells هم عبارة عن neoplastic cells, lymphocytes, but because they are fragile, not normal lymphocytes, will be compressed and destroyed. فبيبين هذا الشكل بنسميه smudged cells. Okay? Almost always in all the cases of CLL, we have involvement of the bone marrow and spleen and liver. This is section from the liver. These lymphocytes are abnormal lymphocytes, okay, involved by CLL. Bone marrow here also, infiltration by the lymphocytes, and peripheral blood lymphocytosis. These cells will show positivity for B-cell marker like CD19, 20, and paradoxically what اللي هو CD5 which is a T-cell marker. Okay? So في عندنا هلا رح نحكي عن two lymphomas أو leukemias expressing CD5 which is a T-cell marker. One of them اللي هم CLL, SLL, the B cells expressing CD5. The course and prognosis of CLL, SLL is variable depending on the disease stage and genetic findings. For example, cases with isolated chromosome 13q abnormality associated with good prognosis, while patient عندهم CLL with p53 mutation shows what? Poor prognostic indicators. Affecting elderly, usually it is asymptomatic, presented with painless lymphadenopathy, hepatomegaly, splenomegaly, hypogammaglobulinemia, autoimmune hemolytic anemia, and thrombocytopenia. Median survival for patients with CLL, SLL, 4 to 6 years. However, there is a risk, small risk, about 5% of transformation to more aggressive forms of lymphoma. في 5% للبيشنت اللي عندهم CLL ممكن يتحول من indolent low grade lymphoma أو leukemia اللي هي CLL to more aggressive form اللي هو diffuse large B-cell lymphoma DLBL. تقريبا هي one of the most aggressive lymphomas DLBL seen in 5% only من CLL can transform to DLBL. إذا صار عمل transformation أكيد survival expectation راح يكون أقل with less than 1 year survival. This transformation called Richter transformation. Okay. طيب second lymphoma, follicular lymphoma. It's called follicular. So with sectioning of lymph nodes with follicular lymphoma, you will appreciate presence of follicles. It's a low-grade lymphoma. تقريبا 40% of non-Hodgkin lymphomas in United States associated with the translocation 14-18 up to 85% of cases. This translocation will lead to overexpression of BCL2. BCL2 is what? Is anti-apoptotic protein. So overexpression of anti-apoptotic protein, this will lead to what? Survival of the, promoting the survival of the neoplastic cells because it inhibit apoptosis. So BCL2 translocation 14-18 with follicular lymphoma. حكينا بالsectioning of lymph nodes in follicular lymphoma, we will see follicles, nodular growth pattern. However, these follicles differ from the follicular hyperplasia, the benign condition or normal lymph node in what? In that it is monotonous. تقريبا they are identical to each other and the full lymph node is effaced يعني ما في cortex, medulla, variation, all the structures موجودة. Lymph node all are effaced by what? By lymphoid follicles. Type. Lymphoid follicles composed of two cell types, centrocyte and centroblast. Centrocytes are small cells, while the larger cells are centroblast. Okay. Centrocytes nuclei show indentation, and linear enfoldings, like a coffee bean appearance. بيكون في عندنا central cleaved nuclei, like a coffee bean appearance. Okay, centrocyte. Centroblast, larger cells with vesicular chromatin and multiple nucleoli. The mitosis in follicular lymphoma is infrequent, and necrotic apoptotic cells are not seen. This point also differentiates follicular lymphoma from reactive follicular hyperplasia, where we see more mitosis and apoptotic bodies. تمام? So the apoptosis with mitosis, apoptotic bodies, more with follicular reactive hyperplasia if we compare it with follicular lymphoma. These large cells, centroblasts, and the centrocytes, small, cleaved, indented, irregular nuclear membrane, small cells, centrocytes. The B cells in follicular lymphoma expressing CD10, CD20, CD19, which are pan-B cell marker, and BCL2, which is anti-apoptotic protein, أصلاً overexpressed in follicular lymphoma. Affecting older adults, male and females equally affected, painless enlargement of lymph nodes, the bone marrow almost always involved. That disease is low grade, however, it is incurable, and it has risk of transformation the same as CLL2, more aggressive form, اللي هو diffuse large B-cell lymphoma, تقريبا more than CLL, up to 40% of cases of follicular lymphoma can transform to DLBL. Marginal zone lymphoma, we have three subtypes. Marginal zone lymphoma nodal type, يعني arising from lymph node, while extranodal types like splenic marginal zone lymphoma arising from the spleen, and maltoma, which is mucosa-associated lymphoid tissue lymphomas, seen in mucosal surfaces like the stomach, small and large intestine, also salivary glands. Related to what this maltoma? Related to chronic infection due to pathogens, infections, chronic inflammation due to pathogens and infections, or autoimmune diseases. حتى بالجنرال باثولوجي واحدة من الكاردينال أو hallmarks of malignancy اللي هو inflammation induced malignant transformation. لما يكون في عنا a chronic inflammation, for example in the stomach, gastritis with repeated rounds of destruction, repair, proliferation many times over a long period of time, the chance of metaplastic changes and mutation will increase. So this will increase the risk of malignant transformation. The good thing about maltoma, for example, affecting the stomach or arising from the stomach, and eradicating the pathogens at the early stages can reverse the lymphoma, can reverse the malignancy, unless it transformed to or became disseminated. Okay. طيب مثال على autoimmune diseases, for example, Sjogren syndrome affecting the salivary glands, also with over a long period of time, an autoimmune and chronic inflammation can induce malignant transformation and extranodal marginal zone lymphoma development. The cells in marginal zone lymphoma are small and resembling marginal zone lymphocytes in the marginal zone. تمام? It's a low-grade lymphoma as well. طيب. Mantle cell lymphoma, from its name, so the cells of this lymphoma resembling the mantle cell or mantle zone lymphocytes موجودين بالmantle cells. It's of intermediate grade, affecting patients older than 50 years of age. It's not common, up to 4% of non-Hodgkin lymphomas. It may have nodules, follicular formation, or diffuse growth pattern, lymph node, diffusely involving the lymph node. The cells of mantle cell lymphoma are monotonous. They look like each other. Monotony is a striking feature with mantle cell lymphoma. They are monotonous, resembling each other, with irregular nuclei and scant cytoplasm. Mantle cell lymphoma arising from the gastrointestinal tract can present as multifocal submucosal nodules, look like what? GI polyps, grossly. In the right picture, you have multiple polyposis or multiple polyps. Under the microscope, we will see what? Aggregates of mantle cell or B cell, abnormal B cells, with immunophenotyping will be expressing the mantle cell lymphoma markers. Mantle cell lymphoma, 100% of cases showing translocation 11-14, fusing cyclin D1 to IGH locus. The B cells expressing BAM-B cell marker, CD19, CD20, and CD5. بالإضافة إلى cyclin D1, which is overexpressed due to the mutation in mantle cell lymphoma. So, second lymphoma expressing CD5 بالإضافة إلى LCL. طبعا cyclin D1 is one of the what cell cycle proteins promoting cycle process, controlling the transmission of the cell from G1 to S phase. So if it is overexpressed oncogene, this is an oncogene, then the cell cycle will be repeated and we will have proliferation of malignant cells. Clinically, the patient may present with lymphadenopathy, widely disseminated disease at presentation, ممكن كمان involvement of bone marrow, liver, and spleen. It is moderately aggressive, it is intermediate, with a survival of 3 to 5 years. DLBL, diffuse large B-cell lymphoma. It is the most common type of lymphoma in adults. It is aggressive lymphoma, and from its name, characterized by diffuse growth pattern. Also from its name, the cells, the component cells or malignant cells are large cells, تقريبا 3 to 5 times their normal resting lymphocytes. These are large cells with multiple nucleoli and scant cytoplasm, suppressing B-cell marker like CD19 and 20 with surface immunoglobulin M and IgG. Clinically, the median age is 60. It is a disease of adults. However, we have 15% of cases developing in childhood. Or 15% of childhood lymphomas are DLBL. Extranodal site or presentation is common in DLBL. ممكن يجي patient DLBL affecting the soft tissue other than the skin, other than the lymph nodes. So it is common. rapidly enlarging mass at one or several sites. So rapid growth of the tumor. على عكس الليمفوماس اللي كنا حكينا عنهم, bone marrow, liver, and spleen involvement is rare, early in the disease. Later on, it is rapidly fatal, of course, as it is an aggressive one. However, with chemotherapy can we reach complete remission up to 80% of cases. Burkitt lymphoma, another aggressive high-grade lymphoma. It has a diffuse growth pattern, translocation 8-14 in almost all cases, or its variant, يعني 8 with other chromosomes. لكن الباثوجنومينيك هو ايش؟ Overexpression of c-MEC on chromosome 8. Okay, it's an oncogene overexpressed in Burkitt lymphoma. It's thought that Burkitt lymphoma is one of the most proliferative tumors in the human being. يعني أكثر tumor تصير له proliferation في human being. That's why it's highly responsive to what? To targeted chemotherapy that's targeting the replication. Okay? We have 3 subtypes. Endemic type, African, affecting the maxilla and mandible. Non-endemic or pandemic, called pandemic in the Western type. Presentation before intra-abdominal, retroperitoneal, ovarian involvement. Immune deficiency type, اللي هو third type. EBV is associated with Burkitt lymphoma, especially which type? اللي هو endemic African subtype. Characteristic histology or histopathology of Burkitt lymphoma is the starry sky appearance. This appearance related to what? These star-like foci are macrophages engulfing the cellular debris. Because of the highly proliferative capacity of the tumor cells, بصير عندنا tumor debris nuclear fragments engulfed by macrophages, giving this starry sky appearance. This is higher magnification. These are macrophages engulfing the nuclear debris or apoptotic bodies. It is a B-cell marker, a B-cell lymphoma, Burkitt lymphoma. So suppressing B-cell marker like CD19, 20, 10, and BCL6. So, we only will talk about T-cell leukemia. It's a CD4 T-cell neoplasm related to infection with the human T-cell leukemia virus, type 1, seen more in Japan and the Caribbean, presented with a skin lesion, this T-cell lymphoma, hepatosplenomegaly, hypercalcemia. It is rare and it is very aggressive lymphoma. Usually أصلاً T-cell lymphoma worse than the T-cell lymphomas. Okay? Regarding the staging of non-Hodgkin lymphomas, it is the same criteria followed as Hodgkin lymphoma. We have 4 stages. Stage 1, involvement of a single lymph node region. Stage 2, involvement of 2 or more, لكن on the same side of diaphragm, or limited contagious extralymphatic organ involvement. Stage 3, lymph nodes on both sides of the diaphragm with limited extralymphatic organ or tissue. Stage 4, when we have disseminated foci of extralymphatic organ, including lymphatic or without lymphatic involvement. خلينا ناخذ حضوريات المحاضرة الأولى. Plasma cells are differentiated B cells secreting immunoglobulins responsible for what? For the humoral adaptive immunity. Okay? And morphologically, the plasma cell are round with eccentrically located a nucleus to the side and what? Perinuclear hoof or pale area representing the Golgi apparatus, perinuclear, containing abundant blue cytoplasm, vacuolated, reflecting the presence of what? Immunoglobulin vesicles. So plasma cell tumor, it's a tumor of the plasma cells, malignant clonal proliferation of plasma cells, affecting middle-aged and elderly patients or persons. The tumor cells secreting single or monoclonal immunoglobulin or part of it, of the immunoglobulin. The immunoglobulin can be detected in the serum as monoclonal gammopathies, and these immunoglobulin اللي هو pathognomonic for a plasma cell neoplasm called what? M protein, referred to these immunoglobulin as M protein. We have different types clinically based on the clinical representation of a plasma cell tumor. Multiple myeloma, which we will talk about in this lecture. We have solitary plasma cytoma, اللي هي عبارة عن single mass of or aggregates of malignant plasma cells, single mass. Primary or immunocyte-associated amyloidosis, amyloid deposition related to proliferation of plasma cells. ايش هو الاميلويد؟ بروتين اللي هو fibrils composed of يعني deposited in an abnormal configuration. Okay? والأمجاس اللي هي fourth clinical variant الأمجاس monoclonal gammopathy of undetermined significance which may transform to multiple myeloma over time. طيب احنا بس رح نحكي عن multiple myeloma. Median age at diagnosis around 70, so disease of elderly, more in males, African origin, characterized by clonal proliferation of neoplastic plasma cells in the bone marrow associated with lytic bony lesions. The most frequent immunoglobulin, اللي هو الأم protein produced by the plasma cells in multiple myeloma, is IgG up to 60% of the time, followed by IgA. 15 to 20% of cases only produce the myeloma cells kappa or lambda light chain. And an immunoglobulin composed of light chain and heavy chain. So either the M cells or plasma cells produce full immunoglobulin, complete of the immunoglobulin with heavy and light chains, or only light chain, اللي هم gamma, kappa and lambda, free light chain, called what? These free light chain? Pence-Jones proteins. So Pence-Jones protein, they are only light chain produced by the M cells or plasma cells. In many cases, بيكون في عندنا production of both M protein, يعني complete immunoglobulin, واللي هو most common ال IgG, and light chains, اللي هم Pence-Jones protein. Pence-Jones protein, they are light in weight, so they can excrete it in urine and can be detected in urine. While the MA protein, if the kidney or glomerular function is intact, will not be excreted, the immunoglobulin, full immunoglobulin. Only detected where? In the blood. الأما protein. تمام? So in blood or serum, we can detect the light chain and the MA protein. In urine, if we have a Pence-Jones protein, the light chain can be detected. Okay? So it is proliferation of plasma cells in the bone marrow, leading to what? To bony destruction. This bone destruction related to what? ايش بصير في عنا destruction of bone? Due to factors released by the plasma cells like interleukin 6, tumor necrosis factor, upregulating or overexpressing the rank L mediators in the stroma في البون. rank L ايش بيعمل؟ بيعمل stimulation للأوستيوكلاست. Main function of osteoclast is lysis of the bone, destruction of the bone. Okay? So we will have lytic bony lesion. طيب لما يكون في عنا lysis of the bone will be vulnerable to fractures, pathological fractures, and this lysis will lead to what? Increase of what? Calcium. So we'll have hypercalcemia. اللي هو which type? Diastrophic or metastatic? راح يكون metastatic calcification. طيب كمان راح يصير في عنا suppression of the normal hematopoietic elements in the bone. The patient will present with anemia. The patient also may present with what? Okay, we have immunoglobulins production, but in this immunoglobulin are pathologic, okay, not normal, so the patient will have increased susceptibility to infection. Clinically, so the patient will have bony lesions, lytic lesion, hypercalcemia, increased risk of infection, and also we have renal manifestation. It is common in patients with multiple myeloma. Type. نيجي pathogenesis of multiple myeloma, dysregulation of cyclin D1 with translocation 11-14 involving D1, who cyclin D1. The proliferation of myeloma cells supported by the secreting interleukin 6 from the bone marrow stroma, and also the myeloma cells secrete interleukin 6 بما حكينا و tumor necrosis factor that induce the expression of rank L in the bone, promoting the activity of osteoclast. So, clinically, multifocal destructive skeletal lesion, which leads to pathological fractures. Bone resorption results from the secretion of certain cytokines, as we said, tumor necrosis factor, interleukin 6 by myeloma cells, stimulating the production of rank L, which stimulates the differentiation and activity of osteoclast. This punched out lytic lesion, bony lytic lesion, is highly suggestive of multiple myeloma, especially if it is multiple. تمام? In the bone marrow, if we take a biopsy from the bone marrow or aspirate, we will see increase in the number of plasma cells. The plasma cells حكينا هاي مثل اللي هون centrically located nucleus, paranuclear half, the Golgi apparatus, mononuclear, usually it is one nuclei. The abnormality will have larger cells, plasma cell, with binucleation and multiple vesicles, cytoplasmic vacuoles. This is the abnormal, okay, the myeloma cell. تمام? طيب, with disease progression from the bone marrow, proliferation of plasma cells, then the plasma cells might infiltrate the spleen and liver and other tissues. We can see other foci of plasma cell aggregates in the body. Patients with myeloma, we said, are immune compromised due to the decrease in the normal or in the level of normal immunoglobulins and antibodies. Renal manifestation in multiple myeloma is common. Related to what? What is the explanation of renal manifestation? First of all, the patient may present with obstructive proteinaceous cast. Immunoglobulins are protein. They may obstruct the tubules in the kidneys and cause obstructive manifestation. These obstructions may be the components of these obstructive proteins like Prince-Jones proteins اللي هم light chain. Also the light chain protein نفسهم الأمي protein, other than obstructing the tubules, they may destruct the parenchyma in the kidney parenchyma, the interstitium and the tubules. Okay? ممكن يصير في عندنا amyloid deposition اللي هو الابنورمال protein deposited and being toxic, leading to renal insufficiency or failure. On the other hand, the hypercalcemia from the lytic lesions can lead to renal stones. Also, bacterial infection are increased in patients with multiple myeloma. So maybe the patient present with bacterial myelonephritis, inflammation of kidney, parenchyma and pelvis. The disease is progressive with median survival of 4 to 6 years. Bone marrow biopsy for diagnosis and electrophoresis of the serum and urine. Diagnosis relies on what? On radiologic and laboratory findings. Definitive diagnosis requires a bone marrow biopsy and examination. To diagnose, briefly diagnose multiple myeloma. The marrow biopsy must shows what? Must show more than 10% infiltration by plasma cells, plus at least one myeloma defining event. ايش هم هدول clinical features? One of them should be present plus 10% plasma infiltration in the bone marrow اللي هم مجموعين بكلمة CRAB, either hypercalcemia, renal failure, anemia, or bony lytic lesion. Okay? طبعا this criteria for the plasma infiltrate from 10 to 13. More than 13, it is definitive diagnosis. We have plasma cell neoplasm infiltrating the bone marrow. Okay? Regarding treatment, we have proteasome inhibitors inducing plasma cell apoptosis, thalidomide analogs as well that alter the marrow microenvironment, inhibiting the myeloma cell growth and survival. In this case, we have a patient, the age of the patient 61, so he is elderly, has a dull, constant back pain for 3 months, so a chronic back pain, developing recently cough, productive cough, so reflecting that the patient has what? Infection, lung infection, which is opportunistic lung infection, okay? يعني مش usual اللي هي common flu or cold, okay? Common cold. The X-ray of the spine shows several, multiple, 1 to 2 centimeter lytic lesions in the vertebral bodies. The culture shows Streptococcus pneumonia, so the patient is immunocompromised. Which of the following pathologic findings most likely seen in bone marrow biopsy? He is elderly, has infection, lytic bony lesion. ممكن يكون عنده granulomas due to TB مثلا. Nodules of small in the bone marrow small mature lymphocytes اللي هم CLL ما بتعمل lytic lesions. RS cells Hodgkin lymphoma no. Numerous plasma cells lytic lesions اللي هي plasma cell myeloma or multiple myeloma بالضبط هي multiple myeloma or hypercellularity with the blast اللي هي ALL acute lymphoma no. So the answer is numerous plasma cells representing multiple myeloma. So هيك نكون حكينا عن معظم malignancies lymphoproliferative with the ALL, T-cell lymphoma, TALL, CLL, follicular lymphoma, mantle cell lymphoma with translocation 11-14. Okay, extranodal marginal zone lymphoma related to inflammation, diffuse large B-cell lymphoma, the aggressive tumor, Burkitt lymphoma, aggressive tumor with starry sky appearance on histology, and plasma cytoma or multiple myeloma plasma cell neoplasm with crab manifestation. حكينا one of them with more than 10% plasma cell infiltration in the bone marrow. Okay, خلينا ناخذ حضور الغياب.